There we go. So I think we're going to go ahead and get started for today's session while more folks are joining. So thanks everybody for joining today's session. We've been running the TB 101 series all summer. Today we're going to be addressing the topic of TB nurse case management and adherence. So if we're thinking about the self-study modules, that will be module 6. So our speaker today is Patty Woods. Patty is the TB nurse consultant for the state of New Jersey TB program. You can't tell by her youthful appearance, but Patty has 20 plus years of experience working in TB, both at the local level and at the state level. She's also been a nurse consultant for the Global TB Institute for many years now. So, and she's also has a leadership role within the National TB Nurse Coalition through the NTCA organization, the nursing subsection. So Patty is well experienced in this area and has been a national resource for quite some time. And we love working with her. So Patty, I'll turn it over to you.
Thanks, Anita. Thank you for that generous introduction. Okay, so I'm going to just shut my camera off now so we don't get distracted, but we'll talk about nurse case management. If you have any questions, just throw them in the chat or feel free to unmute yourself. It's, kind of a relaxed environment here, okay? Let's just... All right, so of course, we're going to start with a definition. Now, case management is not new to tuberculosis. There's case management in a lot of different diseases, but it's a little bit more specific when we talk about TB nurse case management. And the idea is to provide a systematic process that coordinates care for our TB patients. We do this through case finding, assessment, problem identification, planning, implementation, outcome identification, evaluation, documentation, and to ensure an optimal TB treatment outcomes within an acceptable time frame. Now, my nurses out there, does any of this sound a little bit familiar? Maybe like the nursing process? So when it comes to TB case management, like I said, it's a little bit more specific. It came about because when they had the resurgence of TB in the 90s, they were seeing that there was poor outcomes. So we went to the case management system to stop the poor adherence, which was resulting in lengthy treatments and interrupted regimens. So they developed something more specific to TB case management. Now, because TB is within the framework of public health, we're not only managing the patient, we're also concerned about the public health, because it is a communicable disease. So we have a lot of responsibilities as a case manager. And unlike other diseases, the case management is responsible for the care from the beginning to end, and they, assign responsibility to get that person to a completion of treatment. So I do have a poll question. The concept of TB case management was developed in the response to identified program deficiencies, poor adherence rates, results in lengthy interrupted treatment regimens. True. False. Case management was in response to direct observed therapy, or C, none of the above. Okay, I'll give it a few more seconds. And all right, it looks like still got a couple more answering, so I'm just going to give it a few more seconds. And it looks like a lot of you have picked true. So that's good. You're okay, let me get rid of that. Yes, true. It was developed because of the insufficiencies and of course outcomes. But a lot of people do think that it was a response to DOT, and a lot of clinicians sometimes think that case management is just about having someone on DOT. And we're going to find out that it's not, it's a lot more. So why do we need case management? Well, the ATS, CDC, and IDSA decided that it is important, and they put that in the 2016 guidelines. And you can find it in the 2016 guidelines. And they thought it was important because the patient's going to be on this treatment for several months. There's a lot of things that need to be coordinated, and we want to do it as patient-centered care. So what is patient-centered care? So basically, patient-centered care is just making sure that we give actually, quality care to our patients, but it's important that we bring them into the fold and have them part of the decision-making and respect their individual values. And, we want to make sure that they get through this treatment of TB. So an example I can give you of like patient-centered care, what we did in one of our clinics was for our LTBI patients. This was in the day when there was only INH as a treatment option. So it was really a long treatment, and a lot of people weren't finishing, and a lot of people weren't finishing because they had to come back every month for 9 months, and people had to work. So we extended our business hours, our clinic hours. So we had some after hours a couple of times during the month to accommodate that. So that was kind of like patient-centered. We've seen the need that they couldn't finish even though they wanted to because of work. So we extended some clinic hours. So some of the other critical concepts of case management is the case manager is responsible for that treatment from the beginning to the end. So it's our job to really try to get them to finish this treatment once they start it, not only just for TB cases, but our LTBI and our contacts just as well, because if we don't take care of them, they might end up being our case at the end of the day too. So we're not only taking care of our cases, let's think about our LTBIs and let's think about our contacts. So think of yourself as the head of the team. You are the head coach here, and you're going to monitor everything that's going on with the patient and the rest of the team. It's a systematic approach. It's designed to allow patients to experience a continuity of care instead of there being a break in care, and it includes all 8 elements. It's also like sets a standardized system, kind of like, McDonald's. When you go to a McDonald's, you expect a certain menu. You could go to a McDonald's in a different country and there might be a little variation, but you're still going to get your staples of McDonald's. So if we're transferring someone to California, I don't have to explain to them everything we need to do for TB because we're all case managing it the same way, which makes it really nice. Now, some of our goals for case management is 1, we want to make sure there's a nice transition from inpatient to outpatient, or there's no interruption in care. So having that relationship with your hospital's infection control, because that's usually where our patients start, is in a hospital, not always, but we want to make sure that there's no interruption in care. We don't want someone in a hospital that was discharged 2 weeks ago and we don't know. So that patient is either not on meds or they went and got the meds and they're very expensive and they had no way to help somebody navigate that. We also are responsible for stopping disease progression and development of drug resistance. And how do we do that? One of the very important ways we do that is monitoring DOT and providing DOT. There was a case in one of the counties years ago, and the nurse was documenting DOT, but the patient was saying, look, I promise I'll take them later. Then the patient wasn't doing well, and they went in and they found all this medication because the patient wasn't taking it. So that goes to my point of later on, documentation is important, but we are really stopping drug resistance by DOT because they're on it a long time. Each patient receives their TB treatment according to those guidelines and those standards. Well, you would think, well, why wouldn't they be treated correctly? And you'd be surprised how many times I go through a patient's chart that they're in the hospital and they're on a wrong treatment, or they're not on the right amount of medication or dosage. And that happens, more than not, with not necessarily the wrong drugs, but the wrong dosage. So this is my little trick and what I do when I'm going through charts to make it really quick. We know our standard doses for the most part, the weight is going to be like 1,500 PZA and 1,200 EMB. So when I look at that, okay, that's like pretty much a standard dose. Our INH and rifampin kind of stay stable. Maybe the rifampin will be a little lower, but I always start with those two drugs, make sure they're on them for one. And if they're not, why aren't they? And then you remember four numbers. I remember 56 and 75. And if I see a weight of 56 or 75 kilograms, and they're under that normal dose or over that normal dose, if they're 56, they should be under. If they're 75, they should be above. Or you could do it in pounds. I remember 123, 123 pounds or 165 pounds. And if they're under that, I look for something lower. And if they're above that, I look for something higher. So this way you're not trying to calculate milligrams per kilograms for every chart you're looking at. I just remember those two numbers, 56, 75 kilograms and 123 and 165 pounds. We also want to make sure that there is, like I said before, no fragments in care. And we also want to make sure that people get back to their lives in an appropriate time frame. And how we are going to do that is by one, looking at their infectiousness, monitoring it so we can get them back to school or work, and making sure that we're giving those cans if they're infectious. And now if they're a 4+, I'm not going to give them, collect sputum on them every day because it's going to take a while for that to come down. So maybe I'll collect sputum a little bit less for a 4+, which is a lot of AFB. But once it starts to come down and it's, 1 or, you see a first negative, that's when we want to ramp it up and give them that 2 more so we could get the 3 negatives to get them back to school or work. Or if they have to get on a plane, you could do it, or, they really there's a time crunch. You could do them every 8 hours or at least a day apart, but we do. So we do a lot more than just monitor the patient, right? We have to look at the transmission within the community and prevent that. And we do that by finding our contacts, testing our contacts. If they're positive, getting them on LTBI treatment. And after all that excitement of testing and getting them on treatment, don't let the excitement die, because again, we have to make sure they're just as important to get to the end of treatment because they have the highest risk of breaking down within 2 years. Our contacts have the highest risk because we know they're newly exposed or breaking down in those 2 years. And trust me, I've seen it. I've seen contacts come back as patients that didn't either finish their treatment or chose not to take it. And that's an important role that we also have to do. The best way to do that is education, right? We want to educate the patients, the family, the community. Sometimes we have to go out and do, worksite investigations or schools, and it's a lot of education. So education is really key in getting TB individuals on board. We want to make sure that we are reporting this, and we are reporting all our activities to the CDC. And I'm like, trust me, I've been there. I know it's a lot that they ask for, but it's extremely important that these cases get reported. You might be like, why does the CDC need to know what's somebody's A1C, right? But all that data is going to be collected. It might be put into research. We might find things that's going to, again, advance us in TB elimination. And if we're not reporting it and these cases aren't getting counted and we don't have accurate counts, there might not be as much funding for TB in the future. Or if our case rate's going down, that's great. It's good to know, because then maybe we could put more of our energies to looking at curing the LTBI situation. So now we're going to get into our 8 elements of nurse case management. And we're going to start with our first one, which is early identification of patients who were previously unknown to public health officials. Like I said, most of the patients might come from a hospital. Occasionally, you might find them by accident. I mean, we've had patients, maybe you're doing some screening for parolees or B1s or something like that, and then it pops up to be a case. So those might not necessarily be in the hospital, but it's important to evaluate those high risks so we can find them, because when we find them, we give them leakage to care and treatment, and then we can start all those necessary steps that we just talked to stop transmission and collaborate with any private providers. But this is really an important element too. If somebody has tuberculosis in your community, in your state, or however your program is broken down, case manager is ultimately responsible. So if they're going to a private provider, you might not necessarily be seeing them or doing their sputums or doing their labs, but you're ultimately kind of over, you're still case managing that to make sure that they're showing up at their appointments, that they're doing what they're supposed to, and they're not lost out in the community. Oh, we got another poll question. So tell me when this assessment begins, because that's going to be our next element. Does our assessment of the patient begin at the first interview, at the first clinic visit, when I receive the TB report of a new TB case or suspect, or nurses do not assess TB patients? And let's see what right. Right, I'm going to end the poll right now. And, there's no wrong answers. We're assessing all the time. But I like to say I like to start my assessment or my plan the minute I receive that TB report. Because, sorry. Okay. Because I get a lot of information. When I first get that report in, I'm looking at the report and I'm looking at any potential barriers, how infectious is that patient? What is the age of that patient? Could they possibly be in childbearing age and have children at home? Are there any addiction problems that might be a barrier? Are they homeless? So I kind of like to look at that and start my plan right away based on what I'm seeing in that report. But absolutely, we're going to assess again on that first interview and at that clinic visit. We're going to be assessing. That's our second element is assessment. Like I said, we're going to do some data collection. We're going to do this on a timely basis. We do a clinical assessment of the patient. We're looking at a lot of stuff, not just, looking at any kind of barriers. It could be psychosocial barriers. It's usually conducted in our first interview is usually conducted in the hospital. It could be in the clinic or the field. Here in New Jersey, we say to at least start it in the hospital and at least do one interview in the home because we also want to, verify that address. Okay. So we want to identify any actual or potential health problems. A potential problem could be that, this patient is going to go back to their country next month. So that's something that we have to start working on if that potentially might leave. These are things we want to look on. It involves all the disciplines. If there's an error in our identification of a problem, it could lead to an unsuccessful intervention or an unsuccessful outcome. Like going to verify that address. I had a patient in the hospital that we went to verify the address. There wasn't a real address. The hospital wanted to discharge him, and he swore that address was true. And if they did, that person would have been homeless. Or there's situations where the patient has a home to go to, but if you don't verify with the people that live in that home, is he still welcome back? Because sometimes they're not. So, and we're going to do regular reviews of the patient's chart. Okay, so of course, after we do our assessment, the next thing we're going to have to start doing is planning. And our planning is going to include our interventions, our education, any anticipated behavioral outcomes. And it's important to determine the roles and responsibility of everybody in the team. So if you're the case manager, but you have somebody else that's doing TOT, they have to understand their responsibilities, that if somebody's not being compliant or not adhering, or there's anything going on that's wrong, that they have to come back and report it to you. The patient has to be involved and know their responsibilities, that they have to show up for DOT and their appointments. So we're all on the same page. And of course, like I said, a good plan is going to always involve the patient. Now, tomorrow's Saturday, and if I got up and I told my husband, hey, today we're going shopping, and he says, no, we're going fishing. That's because we didn't include each other in our plan, right? So it's not going to go well. Same thing with our patients. We have to include them. So once we include them and something's not jiving, then we have to start to negotiate. Okay, so you know what? Let's go shopping today because it's raining, and let's go fishing tomorrow because it's sunny, right? So we're going to do that with our patients. You're always going to have to negotiate with them and include them, or it's not going to necessarily go as smoothly as planned. Now, after we got our planning done, it's really going to take us to our fifth element, which is implementing it. Okay, so we have to make sure that our plan is implemented. Any services that they need, any education, any monitoring, reporting. Educate the lab, please. And
Sorry, Patty, your audio went out for a little bit, so I don't know if you could repeat the last thing you said.
okay, yeah, I just said it was unstable, but it's back. Okay, good. All right, so our fifth element is implementation. And this is something that we have to take our plan and now we're going to implement it. So let's say our doctor orders drug levels. We don't do drug levels in our clinic. So this is going to take some coordination and implementation. So then I'm going to have to find a lab that does it. I want to make sure that I educate the lab on how to do it, educate the patient how they have to do it, because there's, specific times of taking the meds. And when it has to be drawn, they take the meds, they draw it two hours later. And so this all has to be done, negotiated, and set up. So my sixth element is outcome identification. So now with my drug levels, my expected outcome is the patient goes and I get the results. And I find out, I go look at my plan and I find out my patient didn't go. So now I have to modify the plan and make sure everybody's aware. Now I have to call the lab again and say the patient didn't show. I call the patient and say, negotiate what happened. Why didn't you go for this important test? Oh, well, I don't have a ride. Well, there's another barrier and we got to figure that out. Okay, I'm going to get you a ride. So let's go. Let's get our drug levels drawn and adapt our plan to and implement it again. Okay, and so then we're going to get to the seventh element of evaluation. I'm going to go and get those now that we saw that my plan worked. They went and got their levels. Now I'm going to get those levels. I'm going to evaluate those levels. And that's the short-term evaluation of this. Did my plan work? What's the levels? Are they too high, too low? Are they good? Do I have to tell the doctor and bring him in on this evaluation? Or are we good to go and he can wait till his next appointment? And then we have some long-term evaluations that we do, which I think are really kind of important too. A lot of clinics will do what we call cohort reviews, and these are taking a random amount of charts of patients that finished, and then we'll look at them and we'll look at the national objectives, the national TB objectives, or they call it NTIPs for short, and we'll measure how well did we do with coming up with these national objectives. So let's say, for instance, one of the national objectives is that, let's say, don't quote me on the numbers, but let's say 80% of our patients should have had an HIV test. And I find that 50% had an HIV test. That's a program, that could be a program problem that, we have to go back and look at and say, what can I fix in my program? What can I do to get everybody tested or get that number up? And we have our eighth and last element, which is documentation. And as our nurses know, if it's not documented, it's not done. And you guys out there do so much great, terrific work. And sometimes I don't think you give yourself credit of documenting all that work. So I know when I was doing case management, I was like, I know everything that's going on with that patient. I know that they're fine. They're doing what they're supposed to. And then I moved to the state and I'll go into a clinic and I'm not involved with that patient, but I want to look at the chart and see what's going on with that patient. And then I come through and I say, look, this patient hasn't been here for month. They missed a month's worth, they have missed appointment, and then now it's now a month out and they're still not coming in. And the nurse will say, well, you know what, that's because they're on vacation and I'm doing video DOT. Oh, that's great. So you didn't lose them. But when I read your chart, it looks like they're lost. So it should read like a book. It shouldn't have any missing chapters. I think this is our last poll question. So a TB nurse case management is essential to the goal of TB elimination. True, false, or unsure? Well, I am very happy with these results because everybody said true. You absolutely are critical to TB elimination. Cannot be done without our nurse case managers whatsoever. You got a lot of balls in there, right? You're not just managing the patient, you're managing the family, the community, and you do a great job. So the next piece of that kind of covers the broad end of case management, but now we're going to talk a little bit about adherence. But before we get into adherence, I have a few slides that I think are important about some communication, because I think if you really pay attention to some of this, it's going to make your adherence easier. So it's just simple things. That first encounter with that patient, you don't know how important that is. That is your best time to start building that rapport, show them that you respect them. How would they like to be called? Introduce yourself and what is your role? I don't like when I go to a doctor's office and people are coming in, they take my blood pressure, they leave. I don't know, was that a tech? Was that a nurse? Was that somebody that's, pretending to do something? I always think it's really important if you could introduce yourself and tell them your role. You want to have a caring and open relationship with them. You want to talk on simple terms so they understand. Use those open-ended questions, not, do you understand your TB diagnosis? Yes. No, you want to say something more. How do you feel about your TB diagnosis? Did anyone explain it to you? Well, that's closed-ended, but it's just really important at that first meeting to establish that rapport. Don't go in and just be like, all right, tell me all your contacts, because we're going to get there. They got to absorb a lot. So let's just build some good rapport. Patient education. I always feel like the more you educate the patient, the better. Don't assume that anybody gave them education in the hospital or when you first see them, because even if they did, they might have not heard half of it because of anxiety. So it's always good to repeat. It's okay to go over things again. What's their medical diagnosis? Do they understand? Do they know all the aspects of this medical condition? Effective communication, and that's why I highlighted it, is going to increase your adherence. It really, really will. It's going to stop a lot of unnecessary phone calls and visits to the patient if we got some good communication in the beginning. That means avoiding our medical jargon. I'm a nurse. I'm a TB nurse. I've been doing that, like Anita said, for 25 years. So if I go to a doctor for something else, don't assume because I'm a nurse that I know all your jargon, because I might not. So avoid medical jargon at all costs, no matter who your patient is. Encourage the questions. Pay attention to those nonverbal cues. Are they zoning out? They're not listening to you? Do they look scared? Try to avoid interruptions and distractions. It's terrible when you're trying to get a health history and there's people calling and there's people coming in. It kind of makes the patient feel like the focus is not on them and you don't really care. And sometimes it's unavoidable, but let's try not to do that. And don't use bias or leading questions. Don't say you don't smoke, right? Because now I'm going to be like, well, you assume I don't. And if I say yes, is that a bad thing? I go of course, especially in this day and age, it's, horrible if you smoke and you don't want to have your patients feel that like it's horrible if they're doing something, that's just the perception. Don't give too much information at one time. We have these big long sentences and about their care. And then if you left and came back and said, what did I say? They probably wouldn't even remember half of it. So explain, wait for feedback or responses, assess this physical discomfort. If they're in the hospital and they're getting antsy because you're asking so many questions, maybe you can say, you know what, we'll take a break. I'll come back. Don't be under time pressure, like too much time or too little time. Attentive body language, don't have your face down, just writing and not looking at the patient when you're interviewing them. Listen and respond to their concerns, be respectful of their patient's beliefs. Never show frustration or impatience. We've all been there. We're human. Patients ask you the same questions 15 different ways. And now you're like, I got to move on because I got another room full of patients out there that are waiting to come in. But try to just be patient and remember that they're under a lot of anxiety that I think sometimes, we do this so long and we see such success stories and people get treated that we might get complacent that this is like, this is their first experience with this disease, not their 100th patient that we've seen that we know might do very well. Always ask them for feedback and, look at their facial expressions, see if they need clarification, explain why we ask certain questions, especially like sensitive questions, like, have you ever been tested for HIV? Do you have HIV? Then they're gonna be like, what do they think? Do you inject drugs? What are they thinking about me? Like, and you have to explain, this is just typical stuff that we ask all of our TB patients because it's important to your care, and do it in very non-judgmental. We got to be open to the patient's explanations and beliefs about their illness. And again, you might have to negotiate. I had a patient that I had high LFTs and the doctor wanted, a CBC as well. And I went in and his belief was if I took 2 vials, I was going to take all the blood, that it would make him sicker. So I had to negotiate and just get the LFTs. But, I couldn't go in there and say, that's ridiculous. That's not going to happen because I probably wouldn't have got anywhere. So I respected his beliefs, but then we negotiated and I got not everything, but, the most important thing I needed to get. You want to clarify, add and reinforce, and always, if you can, just give some written material, because again, they're going to hear all this stuff you're saying. They're not going to digest it all. So then they want to go home and like read, what did she just say? Use some questions to your patient. What information do you have about TB? Why do you think you got sick when you did? How severe do you think your illness is? How do you feel about knowing you have TB or LTBI? I mean, even LTBI can be scary, like, oh, I got this TB infection, or there might be a stigma to having TB disease. What problems will you have? What problems will having TB cause you? Now I'm infectious. You're saying I can't go to school or work. And, if they're infectious for a really long time, that might, be very hard on them. We all might have gotten to experience a little bit of that during COVID. If you had COVID and you had to stay away from family or friends, I mean, I was isolated in my own room for like 2 or 3 days and I was just like beside myself. So can you imagine having TB and waiting for not to be infectious? So, we've got to consider all these things. And what do they fear about TB? How do your family members feel about it, having TB? Are they going to, be afraid of you, not let you back in the house, support you? Let them know about their treatment expectations, explain what to expect during the course of treatment. How many pills are they going to be swallowing? Explain DOT, what that means. Sometimes I feel like you got to sell DOT because, if you just go say, like, somebody's got to come and watch you take your meds. Like, I'd be like, why do you have to watch me? I don't understand. But, I kind of like to try to sell it, like a nurse or a healthcare worker is going to come to see you or monitor you every day. If we do videos, you're going to have like some, especially in the beginning, if you're having side effects, you're going to have like a partner with you every day. Not necessarily we have to watch you take your meds every day. But, it's very important. If you explain why you have to do something, you're more likely to do it, especially, LTBI too. We have to explain what happens if they don't take this treatment for LTBI and all the pills that they might have to take, or their risks of breaking down if they aren't adherent. Now, I've had nurses say that I'm not going to tell my patient about all these side effects because if I tell them about the side effects, they're going to start having them. Well, I think it's important that they know some of the about their medication and their side effects. So go over each medication. I like to go over it separately, show it to them, have them, read it back to me. You don't know how many times that, even with LTBI, when they come in for their first appointment or refill, I'll be like, okay, so, how are you taking your meds? You're taking, how many pills are you taking every day? I'm taking 2 rifampin every day. That's great. When are you taking them? I'm taking 1 in the morning and 1 at night. So I found that if I ask them to teach that back to me when I teach them about rifampin, and then they say they take 1 in the morning and 1 at night, I say, no, we have to take it together. So go over it when you first see them and go over it again when they come in for their refills or when they're on DOT until you really know that they understand. Always give some nice written information, go over the side effects. A good example is if you don't tell your patients that their urine might be orange or red on the rifampin, you're definitely going to get some phone calls with a little bit of panic going on. And I like that suggestion with the blood draw I saw in chat. We'll talk about that in a minute. Go to the CDC website. They have some really great information, all pamphlets, and hopefully you can get them. I think they have them in Spanish, but if you're going to give out information, it probably should be in the patient's language so they can understand it. If I have nothing else, and I will give them in English because there is a really great tool. If you go to Google Translate and you put the camera on a document, it will translate it for you. So if you have nothing else, maybe you can show them how to do that. If I want it it's great on menus. If you ever go into a country or a restaurant and it has like foreign information, it's in a foreign language, you take your Google Translate, you put the camera on. I say I want it from Spanish to English. You put it on the document and it translates it for you. Right. So let's now talk about adherence. Adherence is about them getting to take their prescribed treatment from the beginning to the end. So when we talk about adherence, I think a lot of times people think about, oh, they got to be adherent with their medication, but they got to be adherent with everything. I mean, they need to keep their clinic appointments. They need to come in for their labs because we got to make sure, their sputums, make sure they're not infectious or that they're getting better or we have this conversion going on. We're not having treatment failure. Their liver enzymes are not going through the roof. So all this is, part of adherence. And when we talk about DOT, when we could talk about adherence for DOT, we talk about that minimum of 80%. Because as we heard, if you were in one of the treatment lectures, I believe, if we get there have been studies done that if we get a patient to take 80% of their meds, that is adequate to consider them treated without fear of, high risk of relapse. So we use 80%. Once they go under that 80%, now I'm saying you're not really adhering. I prefer 100, but that's the cutoff, 80%. So our adherence does require a partnership between our patients and the healthcare providers, right? We have to have it patient-centered, of course. It should be voluntary collaboration. If they're not adhering, we don't want it to get to the point where we have to go to legal issues to get them to adhere their outcomes. And just remember, we have to assess the adherence, not only for our patients, but again, it's within the framework of public health nurse case management is. So we're also concerned about the community and them becoming infectious again. So treatment for TB, it's a high burden pill counts for a long period of time. There could be adverse side effects. We can actually, like I said, there could even be organ failure for not monitoring really well. So these are all really important things that we have to make sure that we're looking at in our plan. And when we're doing monitoring adherence, we should monitor that often, especially for DOT. So if, like I said, if they're not coming in for their appointments, that's important to know because, we want to make sure they're not having liver failure or anything else. So we have to look at all those things when we're looking at adherence. So some things we can do to promote adherence, we're going to talk about that, but think about this, right? Our adherence is affected by positive experiences, or it's affected by negative experiences. So if you're having a negative experience or having side effects, you don't like your provider, you're not going to want to necessarily continue, or you might not be as adherent as if you had this positive experience. So when we're looking at adherence, we have to look at, is it related to your healthcare system? Is there something there that's not making you happy? Is there something in our social or family that is an issue for your adherence? Is it something personal, like, work or school, or something that's causing this non-adherence? Or is it just side effects and they just don't like the meds? And if it's side effects, we got to work with them to get them through. So there's many different types of interventions. It's best that we look at it's going to be like 3 different things. It's either going to be a problem with the patient, the regimen, or provider, basically. But there are so many different interventions that we can't even possibly cover them all, because it's very tailored and specific to a patient. So a lot of times you're just going to have to get creative and figure out different ways to help adherence. But some of the things we've used in the past is intermittent therapy. Now, I don't know if this is such a big deal with people using video DOT, but in the past, when we were doing it live and people had to show up, or we had to show up, and it was becoming an issue having someone come out every day, we would switch them to like intermittent therapy. Or if somebody is like for LTBI, they don't think they're going to be able to do 3-4 months, or, every day taking meds, maybe we would look at the 3-HP, monitor adherence monthly, if not more. If there is any non-compliance or somebody's starting to fail their adherence, you have to figure that out and address that right away, because it's not going to get better until there's an intervention. Trust me. We use incentives and enablers. And then I think this is a really good tool that helps a lot when you explain to patients, okay, you just missed your DOT today, but you got to realize that if you miss today, you are going to be on it 1 day longer, because we do it in doses. We don't do it in, the doctor might have told you it was 6 months or 26 weeks, which is really 6.5 months. But that's not true. We count doses. So it could be longer, because anytime you miss a dose, it's extended 1 more day. I've had a patient that actually was doing it on video, and she was like, tomorrow's a holiday, but I don't want to be on 1 day longer. Can I call you on the holiday? And I was like, fine, that's not a problem, because it, takes all of 5 minutes. But that worked so well for her that she made me work holidays, which was fun. Use of enablers. An enabler is something that assists the patient in completing their therapy. It could be transportation vouchers, or transportation, doing the transportation, convenient clinic hours and locations. Like I said, that one time we extended our hours for LTBI. At one point, we had so many people in one of the towns, which was like 10 miles away from one of our clinics, that we actually asked the doctor if he could come, and we found a place in one of the other health departments in that town, if he could actually come to that town once a month, because it was just so much easier to have the 10 patients that were diagnosed in that town come to that clinic than 10 patients try to do 10 miles. Have someone that speaks the language of the population served. System. This is a really good enabler. Please call and remind them of their appointments. I would not make half of my appointments if somebody didn't call or text me or remind me. And if you can't do that, we have so much technology now. Maybe we could show the patient how to set up a reminder on their phone or one of their devices. But that really, that made a difference, calling the patient the day before to say, hey, you got an appointment. Or we could do incentives, and incentives are kind of like a little bit of a gift, right? Incentives are interventions to motivate the patient, or enabler, it's enabling them to get to the clinic, or get what they have to done. This is kind of like an incentive to do it. Hey, you did DOT every day this week, so we're going to give you a little incentive. It could be a gift card, it could be books, it could be clothing or personal products, or anything. But most of the clinics, I think, would probably give some kind of gift card. In one of our clinics, we had people donate clothes, so we'd have clothes for that people could come in and take. So when we set up that clinic in the other town where this patient lived, he said, no, I don't want to go to the clinic that's close. I'm going to go to the one that's 10 miles away. And we're like, but it's 10 miles away. And he's like, yeah, but you've got clothes there. So he would come to the other clinic just because we had these donated clothes, and he would come, and every time he would take them and they would go. Now, I'm not going to read through all these because it is in the guidelines, but these are just all examples of different enablers and incentives. So if there's something in there that you want to get creative about, go look and see what the difference is. And, sometimes you can actually reach out. Like at one point, we had a McDonald's by one of the clinics, and they were very happy to give us these little cards that we could give out to kids, get like one of those small little free ice creams. It was an incentive. So like I said, calculating that adherence is minimum. Please do it monthly, but it's really important because that's where you're going to find out what the DOT, if they're not complying. I mean, if you're doing it and you're seeing them every day, I guess you don't have to calculate it every month, but if somebody else is doing it and you're not reviewing that chart all the time, then it's really important that we look at that. And we do that by calculating the number of days of DOT divided by the number of days they should have been available. So in June, there's 30 days in June, and I'm doing video on the AMOCA. So I'm sending the videos. So I should be available 30 days because there's no reason for me not to send a video because I'm sending a video. So I go and I look at my DOT sheet, and I only have 10 videos at the end of the month. So I take the 10 and I divide it by 30, and that's like 33% adherence rate. That's what we call it. Not good. Not good that we, hopefully we caught it in that first month, and then we'd go in and we'd have to again, we assessed it, evaluate, plan what's going on and fix it. But really, really, it's important most important thing one of the things is to, look at those charts often. And I think that's one of my take-home points. If it's not, it should be, but case management is an essential component toward TB elimination. It really is. Thank you for all of you that are doing it, and anybody else out there that's doing any work in TB, healthcare workers wise, because everybody in that team is important for TB elimination. Clinical outcomes, it's been proven that the introduction of our nurse case management model has definitely changed the course of outcomes. They are much better than they were without case management, and use knowledge and tools to overcome challenges and to advocate for our patients. And that is all I have. And now I'm going to open it up for any questions that anyone may have. And I'm just going to go over this tip that I saw. I use for blood draw. I refer that the amount of blood to something relatable. I use a teaspoon. The total amount of blood and I needed to fit in a teaspoon. I love that because when you look at that tube, right, it does look like a lot of blood. I really love that suggestion. Anybody else have any questions, or does anybody have any challenges with any of their patients right now that they'd like to share, since we got what I believe is a bunch of healthcare workers on the line? All right. Anybody having any challenges? And I don't know if you know how to raise your hand, but you can just raise your hand. There is a feature down here that says, I think it's reactions, right? And you can raise your hand. Are people feel that they're doing a lot more TB testing?
There's a question in the chat, Patty, too, from Marilla.
Yeah, I see. That's a really good question. We are definitely trying to change the language, adherence or compliance. It all sounds like a little scary, right? What wording do you use when discussing not adherence with a patient? And I don't necessarily have to say that you're not adhering to the program. We could just say that you're not taking your medication regularly, you're not coming to your appointments on a, when they're scheduled or on a regular basis, and then go right into that education of why it's so important. And I like this question too. Thank you, Shu. Case management responsibilities for extrapulmonary TB cases. Well, that's a really great question. The new CDC guidelines actually recommend that DOT be done on all patients if you have the resources, including extrapulmonary. Before it was like, well, they're not pulmonary, they can't affect the public, so we don't have to necessarily do DOT on them. But like when you think of DOT, it's not just about watching them take the meds, it's about side effects and everything else. So extrapulmonary cases, they might need that extra hand too. So if you have the resources, you should try to do the DOT, but you're still responsible for them. The only difference, like with non-pulmonary and pulmonary, is in the public health aspect, is we can't make somebody, not that we could take pulmonary patients, we can't make pulmonary patients take their meds, but we can confine them. But extrapulmonary, if they don't want to do it, there's really not a lot you can do about it because it's not a public health risk. There is a tool for chart review. I do have a chart review a form that I use, and there's also a specific tool for these chart audits through CDC, I believe, but I will get that information over to GTBI so they can share it with you guys after this presentation. And there is in the chat right now the survey or evaluation. So if everybody can kind of click on that or remember to do it, you'll also get it in an email. And the slides in this presentation will be available if you missed something, or if there's somebody that missed it and wanted to hear it and couldn't make it, or if you need it for teaching. I use these slides, all of these presentations, in my orientation of new nurses. And we are also sharing the link of We Are TB. That is a great organization of TB survivors. It's great for your patients. If you have patients that are looking for support, they have support groups. Or if you have a patient that, if I had patients that they don't want to be discharged and they want to somehow stay in the TB community, they can get involved in this organization and become the TB speaker or survivor. I don't know if any of you's ever had a chance to see him in one of the sessions. We have in some of the trainings or live trainings, we'll actually have TB survivors come and speak. And I have not seen one TB survivor speak that didn't make me cry with their experience. So it really gives you a real good insight into what patients go through that, you might not even be aware of. And if you go to that site, you can listen, you can see some of those recordings too, if you want to, read about what some people had on their journey. And it might give you some insight on how to help the next patient that might be going through that.
Thanks, Patty. Yeah, I thought about that when you were just kind of going over the communication aspect, because sometimes as a healthcare worker, you can, or nurse, clinician, you can provide all the education, but sometimes it's helpful for a patient to hear it from, somebody else who's gone through a similar situation, and also give them hope for the future.
Yes, I think that's really important. And the fact sheets that I had in my presentation, that came right from the CDC website. So I hope that answers that question. They do have INH, rifampin, 3HP. The other really great tool they have with the 3HP is not only the information sheet, but they have a tracker. So I give that tracker to my patient, and it has, for them to document when they took their meds, and I have them bring that back with them to the clinic, and then I make a copy of it and get that in their chart or upload it to their electronic medical record. So that's because they can self-administer, but I love that tracker. It's really a great tool to make sure that they're, a reminder for them to do it. And here's just one other tip and pearl that actually worked before I say the final goodbyes, because I've meant to mention this in the presentation, but when you're going over medication and people as a reminder to take it, especially for the LTBIs, I heard a nurse say this once and she was like, well, put it where your toothbrush is and you will never forget to take your medication. And then I had to go on medication and I'm like, you know what, I'm going to put this where my toothbrush is. And I have to tell you, I've never missed a dose. So that's just my little tip of the day. It is Friday. It is the end of our session. If I don't see another question, then I am just going to say that we are here next week, same time. And I don't remember what the talk is next week because I didn't look it up because I was doing this, but we will see you here next week, same time at 10 o'clock for the rest of our TB 101. Everybody have a great weekend.
Thanks, Patty. Bye, everybody. Have a nice weekend, and we'll follow up with some resources as well as a link, updates on when the recording is available. Have a great weekend.